Well, good evening, everyone, and welcome to a new edition of Secrets of the USMLE, how to dissect any question on test day. I'm your host, Jeff Downing, and really pleased to be with you here tonight as we work to introduce some ways that you can slice and dice board-style questions, while also walking you through some real-world examples from USMLE-Rx. We are very fortunate to have Dr. Abraham Titus with us tonight. Oh, hold on. My system is a little...
Well, it's jumping around a little bit.
It is jumping around, but go ahead and introduce yourself, Abraham, while I work to fix this glitch.
All right, pleasure to be here. Thank you, Jeff, for the great introduction. So my name is Dr. Abraham Titus. I'm a hematology and oncology fellow at the University of South Alabama. I've been a USMLE tutor with Scholar RX for quite a few years now. I've taught many students such as yourself prepare for USMLE Step 1, 2, and even Step 3. So today we're kind of targeting some common mistakes, common ways to dissect questions, and we'll even throw in a few practice questions that we can kind of put some of these tools to use in. So as we pull up here, we're gonna kind of go into that a little bit, talk about the agenda, what we have coming up, tools we have available, our approach to questions in general, and some tips about dissection, tips about how we study for the USMLE. You know, it's a marathon, not a sprint, and the day of the exam tips. And then at the end, we'll kind of wrap it up with, there's a raffle and a special offer. I think Jeff will talk to you more about that. And then a Q&A at the end there. So I think he's almost got it pulled up. Oh, got the full desktop there. There we go.
Okay. Thanks, everybody, for your patience. So now that you've had a chance to learn a little bit about us, we'd like to meet you. So what we're going to do is we're going to launch the first poll of the night. And this is going to be the easiest question, we think. Go ahead and let us know, who are you? Are you an M1, M2, M3, M4, or are you an IMG or an FMG? Go ahead and let us know. So we use the quick poll throughout the session to capture your input, especially when we get to the point where we're dissecting questions. So once you've mastered this, you're going to be fine. And once we get to a point where about 75–80% of you have voted, we'll go ahead and close the poll. It looks like we've reached that threshold. So what I'm going to do is close the poll and share the results. And it looks like we've got a good, strong showing from the IMG and FMG crowd. We've got quite a few M2s and some M3s here, and a smattering of M1s and M2s. So, especially for you M1s, you may just be trying to get oriented, right? Trying to figure out what Step 1's all about, and what differentiates some of these questions from questions you might be seeing on quizzes in class. So we're glad that you're all here. So this is great. I've got one more question I am going to ask, and this is about when you are planning to take Step 1 or Complex Level 1. Not quite sure how many osteopathic students around here, but go ahead and let us know when you think you're going to be taking one of these exams. You're going to be doing it here before the end of the year. You're going to do it first half of next year, second half of next year, or 2026, or maybe you're not sure, which is just fine. But it kind of gives us a sense of where folks are on their journey. You guys are doing a great job in terms of voting. So already 80% of you have voted. So let's go ahead and close the poll. And we'll share the results. And this is good. So yeah, about a quarter of you are planning to do it before the end of the year. So hopefully you'll get some advice that you can apply straight away. Almost half of you are going to be taking in the first half of 2025, and then the rest of you, July and beyond. So that's good. Gives us a sense of who's here, and again, we are glad that you're here. So I'm going to hide those results, and Abraham has already kind of gone over our agenda for tonight, and as he mentioned, we do have a raffle that is going to take place at the end of tonight's event. Somebody is going to walk away with a subscription to RX 360 Plus. So you do need to be here in order to win. So make sure you stick around for that. We do have a question box where you can ask questions of our team. Kat is here to answer those questions. But the thing is, we have a large audience, so apologies in advance if we're not able to get to all of your questions, but we're gonna do our best. Okay, so with that, what I want to do is turn it over to Abraham to provide a bit of an overview on USMLE.
All right, thank you, Jeff. So we're going to talk about USMLE Step 1. I know a lot of you guys, I saw the breakdown, about 25% of you guys have it coming up soon. So a lot of this stuff may not be necessarily new to you guys, but the people that are kind of a little bit away from the exam, they may not have fully thought about what the exam consists of and kind of what's important in the exam. So the USMLE Step 1, it's about 280 multiple choice questions, and there's always one best answer. So you're never going to pick multiple best answers or option A and E is correct. It's always just one best answer. There's a few multimedia questions. So this can include videos, audios where you have to click around on the chest for the stethoscope and listen, or pictures, EKGs, all kinds of things like that. Mostly clinical vignettes. There are the occasional rare question where they'll say the scientist is developing an enzyme that does this. The majority of the patients cases are going to be a patient walks into your clinic and is presenting with this, or a patient has recently traveled somewhere, something along those lines. A clinical vignette is most common in this situation. There's around 80 experimental questions. Again, they are random. You're not going to know which ones are experimental and which ones are part of the exam. This helps the test writers determine the validity of the test and how they can use it for future exams. If those don't count towards your score, no point in trying to guess, is this an experimental question or not? Just answer every question like it's going to count. But there is this 25% of questions that do not count towards your score. Most questions do require multi-step reasoning. It's not your simple, what is this and end of that. Majority of questions do require a few steps, and we're going to talk about that as we break down the question, about thinking about how many steps the question is going to take, and we're going to talk a little bit more in detail about that as well. And like I said, 280 questions, so that's 7 blocks, about 40 questions each. Some of them are multi-step questions, so it could be like a 2-parter or a 3-parter where one clinical vignette applies to multiple questions. You're going to see a little bit more of that as you get into Step 2 and 3, but Step 1, you're going to see a little bit of that as well. So just kind of a quick breakdown of the types of questions you're going to see and some important things to keep in the back of your mind as you approach these questions.
All right.
I want to quickly talk about RX Bricks. This is a tool that will be kind of very useful for USMLE Step 1. I wanted to talk about it quickly before we jump into everything as well. This is the endocrine system here. They kind of talk about it. What you can do is something as high yield as like the renin-angiotensin-aldosterone system. You can click it. There's a few free ones online that you guys can check out, see how useful they are. They kind of talk about certain learning objectives at the bottom there, and you can even listen to it via audio. And they've just recently updated a lot of these, and you can see last updated May 2024. So they have the most updated information on there, and it will really help build a good foundation for a lot of these concepts, especially things like the RAS system, which is never going to leave you throughout medicine. So it's something that I think it's a great resource, and it is available for RX subscription users for sure. So if you go to the next page, there's also at the bottom of it, it'll kind of go deeper. So they have, first aid facts that you can always connect to. There's always, if you click through, it'll take you to the exact first aid page that explains each concept and teaches you those concepts. Pre-built flashcards, questions that are associated with this, as well as express videos as well. So I think this is a great resource. You can definitely play with it, use it to supplement your studying. Definitely question-based learning is the best way to study, but this is a great supplement to help kind of lock in some of these concepts, especially the really high yield concepts that you just feel like, hey, I'm getting these questions wrong again and again. I need to go back to getting that foundation built. All right, and let's go to the next slide. Breakdown. Okay, so the big 3 Ps are what's high yield here. I think that pathology, physiology, and pharmacology are going to be a lot of your exam. Definitely, you need to know all things. You need to know your anatomy, you need to know your genetics, everything like that. But where the meat of the questions are going to come from are pathology, physiology, and pharmacology. And this is straight from the USMLE website. And then if you look at the top 2 as well, they are talking about diagnosis, 20 to 25%. Patient care and diagnosis. This number jumps significantly more for step 2. For step 1, there are still clinical situations you need to diagnose patients, especially the more common stuff that you can expect to see. Foundational concepts, 60 to 70%, and that's big step 1. That's your basic science concepts. That's your things asking at a more molecular cell level, things like that. And that's still a huge part of the exams, applying those concepts to clinical situations. And that's 60 to 70% is pretty much your exam. So you need to really get those concepts down and really practice those with the questions and through repetitive learning. Let's go to the next slide here. All right, so let's kind of talk about our approach to questions, how we go through step by step. What do we do? So the first step I always recommend, cover up the answer choices, right? So we have, there's always questions and there's people jump right to the answer options. And sometimes it can either be intimidating if they see an option they don't understand or recognize. It may be something you're weak in, or it may just be something that's like a very attractive option that pops out to you right away. I want you to think about the question just by reading the question without jumping to the answer right away. So I always covered out. First thing I should be looking at, let's go to step 2, is reading the last sentence first. Okay, so the lead in for the question is the most important thing. I've tutored so many students where they're able to think about the question, understand what's happening, but they don't understand what the question is really asking. Reading that lead in will kind of prime your brain to know what you're looking for, what to be thinking about. And then as you go to the lead in, highlight the keywords. Are they asking about diagnosis? Are they asking about what the next step in management is? Are they asking about mechanisms? So all these things should be going through your mind as you read that. Let's go to the next slide. Step 3, right? What should I do? So how many steps is the question going to take? And like I mentioned earlier, is this something like a 1-step, a 2-step, or a 3-step? You want to get into the mind of the test writer. You want to see what concept are they trying to get me to learn. All right. And step 4, now we start reading the question, right? Now you're getting to the meat of it. Some of the vignettes are really long, some of the vignettes are really short. Don't get intimidated by the size of the vignette. Focus on what you're looking for. You've already primed your brain using the lead in. So when you read it from the beginning, 1 sentence at a time. I know it's very tempting to just skim it really quickly and just go over it. I recommend reading it 1 sentence at a time. And as you read it, stop and think, what information am I getting from each of these sentences? And what am I learning? So that's what's the most important there. As you go through, highlight. And then when you get to the bottom of that sentence is when I'm going to go, okay, let me think about potential answers. You want to think about this for lab values. You want to think about this for images as well. And then on the next slide, what they'll say is when I get to the end, I want to read that last sentence one more time. I want to confirm, okay, this is what the question is asking. All right, let's go to the next slide. Now you uncover, right? So you have already thought about what the answer options could be. You've thought about what the situation is. And then now when you uncover, when you see an option that you've already thought of, that should make you feel better. Make you, okay, I thought of this without even looking at the options, and I do see it there. Now, how should I pick an answer? Well, I begin reading the choices, last option first and going up, right? That's something that's psychological. When I read from the top to bottom, more likely what's happens when I see an answer I like, I pick it, I don't read the rest of the options. That's not good. It's always the best option, right? There could be questions with multiple answers, could be a right answer. There's always one best answer. So I think starting from the bottom, going up is a good strategy to help kind of mitigate that psychological effect. Cross out the incorrect answers, select the answer which you believe is correct, and then try to stick with your gut feeling, right? Don't try to pick an answer and then start questioning yourself. There's a reason why you picked that answer. There's a reason you got to trust your work that you put in, the education you did, and we'll talk about that a little bit more in detail at the end. All right, let's go through a question here. This is some practice question, and I think Kate, hopefully you know how to work the poll system. It's a little tricky. Well, hopefully we can get this done. So let's go through this question again. As you notice, the options are completely gone, right? So we're going to use it just based on the strategy of dissecting these questions. So what am I going to read first? I'm always going to read the lead-in first. In which area of the adrenal gland is the one functioning steroid hormone produced? Right? So it's not asking me about diagnosis. It's not asking me anything. It's asking what area of the adrenal gland is steroid hormone produced? So right away, I should be thinking, what are the different areas of the adrenal gland and what are the hormones produced in each one? Then I go to the top. An 18-year-old woman is referred to a specialist because she has not yet begun to menstruate. She reports generalized weakness and occasional bouts of nausea and vomiting. Her blood pressure is 160/99. Heart rate is 92, respiratory rate 16. Physical exam is noticeable for a lack of breast development, consistent with Tanner stage 1. Laboratory studies show serum potassium level of 2.2. She's diagnosed with a condition that decreases the production of 2 of the 3 major adrenal steroid hormones, leading to an excess of only 1 functioning hormone. So they're already kind of priming you to think of a diagnosis based on that. So let's put the highlights in there. So let's go to the next one. All right, so these are some important things that we want to catch and what I think is most important, right? So we talked about area of the adrenal gland, steroid hormone produced. Go to the top, 18-year-old. I always like to think about, what demographic am I dealing with? What's their problem? Not yet begun to menstruate. Blood pressure is high, and they have lack of sexual development. Potassium is low at 2.2, and the question is telling you there's 1 hormone that's up and the rest are down in the adrenal gland. So using this, you have to start thinking about, okay, what is a diagnosis of this patient? What are the hormones that are being produced? What are the 2 that are decreased? And what is the 1 that is excess? Use the clinical picture, use the physical exam to get to that diagnosis, right? So this is a multi-step question, but you want to still think about it. So now let's look at the options. And if you've already kind of in the back of your mind, oh, I know what this area of this is. I know what hormone they're talking about. You should be able to get to the answer. But let's look at the options here, and then we're going to throw the poll up, and we're going to see if you guys get this as well. Option E, zona reticularis. Option D, zona glomerulosa. Option C, zona fasciculata. Option B, the medulla, or option A, the capsule. Okay, so different parts of the adrenal gland, which area shows that the steroid hormone is being produced the most? So why don't you guys pick an answer, and we're going to walk through it and explain each one. Yeah, so the answer, option D, zona glomerulosa. So great job, guys. 44% of you guys got that correct. Great job. In the question box, why don't you guys tell me what hormone they are talking about? All right, while I wait for that, let me start talking about what the other options are and why we are talking about it. Great job. I see a few answers in the options here. Aldosterone. All right, so let's break down. Let's go to the next slide here, and let's kind of pop open the options again. Let's kind of go through that one more time.
It's working on mine, but I'm going to try it again because it's not showing correctly.
Oh, just popped up and then went away. Yep.
Well, of course it did. Okay, I'm going back one. No, we're still not seeing.
Still, yeah, it doesn't show it.
Okay.
So we want to go to slide 20, and then if we can full screen that, that'd be great.
Yes.
But I'll talk regardless. Oh, yeah, we got the.
We have it somewhat.
Somewhat. But anyway, we'll keep going while she's trying to work on that. Oh.
Nope. It has a mind of its own like Jeff's. It's good to know that it's not just me.
Okay, so zona glomerulosa. Okay, so again, this goes back to that classic first aid mnemonic, GFR, right? The starts salty, sweet, sex, right? That's the mnemonic, right? So G, glomerulosa, is the most outer layer of the cortex. Obviously, the capsule is the most outer layer, but we don't count the capsule. Capsule is just a capsule. Inside the capsule, the adrenal cortex is made of the glomerulosa, fasciculata, then reticularis. The glomerulosa is responsible for the salt, so the aldosterone, and aldosterone's job is to bring in sodium, get rid of potassium. That explains the hypertension and explains the low potassium levels. And the 2 that are deficient in the situation would be the ones in the fasciculata and the reticularis. The fasciculata would be the something that would be responsible for making cortisol, and the reticularis is responsible for making androgens, and that's why she's not developing any secondary sexual characteristics. What would be the medulla responsible for? Medulla, I want you guys to think, it is got to do with catecholamines. So if we're going down the pheochromocytoma route, then that's what we go for there. That's the medulla. And the capsule, again, that's usually not the right answer. We're not going to go with the capsules as being an issue. It's still showing the presenter view, but that's fine. As long as we can see it, that's okay. So let's go on to question number 2. I know we're running into a few technical difficulties, but bear with us here, guys. You're doing great. First question, you guys are able to get correct. So let's go with question 2. Again, question 2. This is, again, no option seen here. We're going to quickly go through this. Read the lead-in first. Which of the following antibodies is most likely to be found in the patient's blood? So we're looking for antibodies, right? So think about diagnosis. Think about what antibody could be seen in that. A 47-year-old woman presents to the physician complaining of weight gain, fatigue, and lethargy. The symptoms started about 5 months ago and have progressively worsened. She's been doing daily morning walks, but now can only walk about half a mile before feeling too tired to continue. Her blood pressure is 100/50, pulse is 52. Physical exam shows dry skin and delayed ankle jerks. Thyroid gland is mildly enlarged with no tenderness on palpation. A fine needle aspiration biopsy was done, and that revealed lymphocytic infiltrates with few germinal centers. So a few buzzwords there, few things that are going on. Why don't we try to think about what's going on here and break down the highlighted parts there. All right, following antibody. So antibody is a key word there. Again, age and sex of the patient, 47-year-old female, weight gain, fatigue, lethargy, 5 months, dry skin, ankle jerks, those are key there. And I would even say, like, the pulse rate of 52 is a little bit low. All right, so let's start with option E, anti-thyroid peroxidase. Option D, anti-mitochondrial antibody. Option C, anti-centromere antibody. Option B, anti-U1-RNP antibody. And option A, anti-TSH receptor antibody. Each of these are correlated with a different condition, and each of these are high yield in its own clue. But it's in this situation, a patient with weight gain, fatigue, lethargy, a middle-aged woman with some delayed ankle jerks, dry skin, enlarged thyroid, and a biopsy that reveals lymphocytic infiltrates. I want you to think of the diagnosis for this patient, and you can drop it in the question box if you guys think of it, and think about what antibody could we see in that diagnosis. So take your time, think about this, and let's get this poll up, and let's see if we can get this to work. All right. Why don't you guys go ahead and answer? A and E. So let's look at what the answer is. And great job, guys. You guys got the anti-thyroid peroxidase antibody. And I think I saw a few people say it was Hashimoto's in the option. Very good. So this is the classic situation of Hashimoto's leading to hypothyroidism, right? As we know, Hashimoto's is a thyroiditis, at least inflammation and destruction of thyroid. So that's why we see these lymphocytic infiltrates inside the thyroid when we take a biopsy of it. When we see other things we can see in this situation is we get a transient hyperthyroid state followed by a late onset hypothyroid state. So she's been having it for about 5 months and it's progressively worsening. So it's been going on for a while. The hypo, like the feeling cold, the weight gain, fatigue, lethargy, those are the classic presentations that they'll talk about. The heart rate being a little bit low is also a big clue. And the ankle jerks being delayed and the dry skin is also a big clue. So lots of clues pointing towards hypothyroidism. But what about the other options, right? So there is a page on First Aid where I would say it's very high yield, going over the antibodies, and they list them all off and kind of all associated with different conditions. Let's go through it. You guys, a lot of you guys picked A, anti-TSH receptor antibody. What do you guys think that is related to? I'm going to see some of you guys drop it in the answer. Yep, Graves' disease. Great. So this would present as hyperthyroidism. Exactly. So anti-TSH stimulatory antibodies are seen in Graves' disease. And these people would have weight loss, feeling hot, tachycardia, increased reflexes. So really a different presentation than what's happening here. They'll also have the classic exophthalmos with the eye changes. They can have pretibial mixed edema, so things like that. Lots of these things that are going to be seen in Graves' disease. What about option B? That's a weird one. Only 1% of you guys picked that, and that's not one that we commonly see. But what is this anti-U1-RNP antibody? Anyone want to guess in the question box? All right, I see somebody picked the right answer. It's mixed connective tissue disease. Okay, so this is kind of this overlapping scleroderma-like, SLE-like condition. That's why it's called a mixed connective tissue. So I just had features of a few different conditions together, and not as high yield as some of the other options, but it is something I want you to be aware of. What's anti-centromere antibody? That's a high yield one. Let's see if I'm going to drop that in the option. Good. I see some people popping in the right answer. It is associated with systemic sclerosis or scleroderma. Okay, so that's a high yield condition as well. Okay, and that's helps us separate from a lot of these situations as well. Good. And anti-mitochondrial antibody, what is that from? That is primary biliary cirrhosis. Good job. I see that in the options as well. Great job, guys. So you guys pick this all correct. Go to that page on first aid, learn those. This is one of those few things that it's worth memorizing. Most things we kind of understand, conceptualize, but these are antibodies. Unfortunately, they're sometimes not really associated, right? What does anti-mitochondrial got to do anything with the biliary cholangitis or biliary cirrhosis? Not really. So you just have to memorize that. So that's something that's worth for sure memorizing. Very high yield. Definitely will come back on exam day. All right, let's go do the next question here. Go through this one. All right, so this is a little bit of a meaty question. We got a little bit of a bigger vignette here, some labs this time, and this one is a little bit of a trickier question. So I'll tell you guys that much when we start off. Okay, so again, options are whited out. We're not looking at the options. We're looking right at the lead-in first. Which of the following is an adverse effect of the patient's medical condition that likely delayed his diagnosis? Again, this is a little tricky question. So you want to think about medication, adverse event that delayed diagnosis. So it's a multi-step question. You want to think about what concept are they trying to test me here and get into the mind of the test writer. Looking from the top, let's read from the top of the vignette. A 68-year-old man with type 2 diabetes, hypertension, and a recent myocardial infarction presents to clinic with weakness and confusion. He's been seen several times this week for similar symptoms, but sent home when his history and physical examination failed to reveal a cause. His temperature was 98.1, right? Blood pressure 146/88, and pulse of 82, respiratory rate of 19. On exam, his patient has dry oral mucosa and decreased skin turgor. Medications include rosiglitazone, atenolol, captopril, and a baby aspirin. At this visit, the physician decides to draw labs. Labs show sodium of 140, potassium of 4.9, chloride of 101, bicarb of 23, calcium of 8.7, magnesium of 1.6, phosphate of 3.5, BUN of 25, creatinine 1.3, and glucose 1,010. So got some kind of significant findings in this. Our job is to kind of pick those out, try to catch what's wrong. Look at his medications, right? Because there's adverse event of the medication. So read that last part again. Which of the following is an adverse effect of the patient's medication that likely delayed the diagnosis? So he's been to a doctor several times and still not getting diagnosed. What happened? Let's highlight some keywords right now and before we jump into the options. All right, so adverse event of the patient's medications, right? Type 2 diabetes, hypertension, recent MI, those are all high yield. Has weakness and confusion, that's the clinical presentation. Labs don't look too remarkable, right? Temperature's okay, blood pressure's okay, heart rate's okay, respiratory rate's okay. Dry oral mucosa, decreased skin turgor. Rosiglitazone, atenolol, captopril, baby aspirin. You want to think about those meds, think about their side effects, think about the overall situation. And then the labs, things that jump out to me, creatinine 1.3, that's a slight elevation in creatinine. And glucose 1,010, that's significant elevation. Rest of it, nothing too crazy jumping out at me right now. So what do you think is going on in this situation? What delayed the diagnosis? And what medication do you think is to blame for this diagnosis? So I want you guys to be thinking about these things. Now let's look at the options and let's try to figure out what's going on here. All right, so we have option E, sedation, option D, renal insufficiency, option C, rebound hypertension, option B, masked tachycardia, and option A, hyperlipidemia. Right, so think about these medications, think about their side effects, and think about what delayed his diagnosis. Take your time, focus on what the question is asking, what you know, and then let's take the poll and let's try to pick the best answer possible.
We had over about 72% of you have voted, so I'm going to go ahead and close the poll and share the results. So about a little over half of you went with renal insufficiency. About 1 out of 5 went with masked tachycardia. And then we've got, some of you went with rebound hypertension and hyperlipidemia. A couple of you were thinking sedation. So let's go ahead and hide the results and share the answer. And the answer is answer choice B, masked tachycardia. So about 1 out of 5 of you got this one right. And something about this question that led many of you down the renal insufficiency path. So, and that's okay. Abraham's here to walk you through it.
All right. Well, don't worry about getting this question wrong, guys. This is a tough question, but I did want to include it just to kind of reiterate the most important points that we're making here about reading that last sentence and making sure we understand what the question is really asking us. So let's break this question down. Let's go into why that is the right answer and why renal insufficiency, although it's a good answer and there is some creatinine elevation, would not be the correct answer. Okay. So first of all, let's go through the medications. There's the rosiglitazone, atenolol, captopril, and a baby aspirin. Baby aspirin, unlikely to be many issues. If you're going to overdose on aspirin, you're going to get something like tinnitus, and you're going to have acidosis and going down that route. So we're not taking that. Captopril is an ACE inhibitor, and it can cause some renal injury if taken in a dehydrated state. So that's something to think about. But did it delay the patient's underlying diagnosis? What was the patient's underlying diagnosis? The patient has glucose of 1,000 and kept having episodes of weakness and confusion. So what could that be? And of note, the patient had a recent MI. So after the MI, the patient might have had some medication adjustments or something along those lines. So what medication could have been recently added to this patient? The atenolol, a beta blocker, right? So a beta blocker, if it was added, there may have been some new component that have added to what's going on here. So I want you to think about what's going on here. If the patient's glucose is 1,000, they're severely hyperglycemic. If they're severely hyperglycemic, they can fluctuate from high to low, and that can lead to hypoglycemia and hyperglycemia episodes. Both can lead to a fast heart rate and tachycardia. And in this situation, the patient being on the atenolol will mask the underlying tachycardia and will not make it clear that the patient is either hyperglycemic or hypoglycemic. Normally, if a patient like such as me or you, our glucose goes too low or too high, our body is going to let us know. We're going to get tachycardic. That weakness and confusion is generic symptoms, but the tachycardia and that sympathetic drive that our body goes into will turn on. When we take beta blockers, especially in diabetics, they have to be very careful because those symptoms of a really high sugars and really low sugars get hidden. That tachycardia that they would get is masked because the beta blocker is turning off that sympathetic drive. That's something to be aware of. And that's what delayed the diagnosis. So it's not asking you what caused the AKI, what caused anything else going on, what caused the renal insufficiency. It's asking you what delayed the diagnosis. That's what this question is really driving home here. And that's why I put this one here. Although it's a tough question, and I know a lot of you guys were going down, okay, what's the underlying problem and what's the medication adverse effect? I want you to think what delayed diagnosis. And whenever they talk about that, the concept that they're trying to test is the concept of masked tachycardia, the combination of beta blockers in diabetics. And that's a high yield concept. So definitely will be tested. So make sure you guys go with that. All right, good job, guys, though. Overall, definitely a tough question, but we'll, this is like kind of a good wrap-up question to really hit home the point about reading the last lead-in sentence multiple times to understand what they're asking.
Yeah, this is, again, tonight's session wasn't really just about knowledge, right? It was about, kind of helping you, make sure that you are ready and that you've got your technique sharp. Because one of the things that we've learned is that, med students, often make common mistakes, for those that either struggle with step one or even just struggle with, just these board style tests in general. So at the IAMC conference, we had a couple of presentations that talked a little bit about this. And so these were some of the common mistakes that they have correlated with, students who struggle and part of the reason why they struggle. So number one, not reading the lead-in first, right, to understand what information they need from the vignette. That was, something that that Abraham has been hammering home. Reading, let's face it, this is, this is not a video test, right? You're reading all of these scenarios and all of these questions, and so in some cases, students will skip read, right? They'll miss or skip keywords in the vignette, and some of those, contain the information that they actually need for the answer. In other cases, they overread. So sometimes, maybe you've done this yourself. It's like you're learning about a case, and then you're adding information based on what you think that might be afflicting the patient, and that will obviously lead you down the wrong path. Some students don't make the connections or have trouble making the connections between all the information in the vignette. That last one was a perfect example, right? You've got all kinds of you got a hefty story, and you've also got all these lab values, and you need to make sense of it. You're not some struggle when you're trying to connect the dots. A big one is not attempting to answer the question before seeing the answer choices. Right, we talk about covering up those answer choices so that you don't get distracted or perhaps waylaid by maybe a term or a concept that you've struggled with. But the other part of it is like, hey, with the information that you're getting within the vignette, can you answer that question? You should have a hypothesis, right? Before you actually see those answer choices, and then you're actually really working to confirm what you believe. Some students will assume that abnormal findings are significant, or that normal findings are irrelevant. And the USMLE test item writers are they can be very crafty. So these are not assumptions that you want to make. There's normal findings are often relevant, and the same thing, just because there are abnormal findings you don't want to attach too much significance to them. Some students get tripped up by thinking that an answer choice it's just too easy, right? Oh, that one's that can't be right. And you need to resist that kind of thinking. You also, some students will over rely on buzzwords or phrases, and or they'll under rely on their own knowledge base. So that kind of goes back to that, that point about, not attempting to answer the question. You may be able to answer that question without seeing any answer choices. And so, you don't want to just, get, distracted by a buzzword or, not. Sometimes we call it trusting your gut, right? But it is, it's your knowledge base. It's all the stuff you have gathered over time. And then finally, time management is such a big deal. Some students allow themselves to get stuck on a really tough question. And Abraham noted, I mean, you're going to have a huge chunk of questions, a significant chunk of questions that you're going to see in test day that are experimental, right? They're not, they may be really hard. but they may be very hard for a reason, and they don't necessarily count. And then also in the same vein, sometimes if you're waffling on a couple of answer choices, some students will allow indecision to eat away at their time. So these are some common mistakes. These are some things that we want you to keep in mind, and I'm going to pass it over to to Abraham to really kind of underscore a couple of the the tips that you need to be thinking about.
Great points that Jeff made right there. So definitely we're going to talk a little bit more about the question dissection strategy. Some of the things he mentioned I think are really important, like thinking normal findings are always irrelevant and always thinking that abnormal findings are always relevant. That's a very big one that I see a lot. So like a PE, you're not going to necessarily hear anything. Clear lung sound, although it's a normal finding, that's an irrelevant finding if we're trying to go down a PE route. So lots of things like that, you will get the skill as you train and practice with questions, but definitely very important. Dissection tips, right? Have an approach, right? Always have a consistent approach when doing questions. Don't be chaotic, don't jump around, do the approach. I find that the approach that we talk about reading the vignette, reading the lead in, then reading the vignette, then reading the options is a great one. And I would try to stick with one approach that works for you. Again, when selecting answer, utilize all the information. If they're giving you an EKG, if they're giving you an image, they're giving you audio, use that to weigh in on your decision. Don't rely only on the EKG or only on the image. Use the vignette as well. So everything you have, put them together, build a story in your mind, and get to the answer. Each question is created to test a related topic or content area. And that goes to the getting into the mind of the test reader. There's a concept that they want you to know as a doctor that they're testing here. They're saying, okay, this is a concept you need to understand. Step one is a little bit more basic science concepts, but that's still very important, right? Certain topics are tested for a reason. You're going to see it multiple times in all question banks, and that's something that they'll test. They'll put it in a different way that you've never seen before, but it's the concept is the same. Try to get into the mind of the test reader. Again, hits on that again. Determine what their concept is being tested. Great. Let's go to the next slide. All right, tips. So study tips, I think this is very important. Again, establish a study schedule. Stick with it. Find what works for you. Find a good balance between getting reading, videos, flashcards, whatever you use, and questions, right? Questions and doing questions multiple times is what is going to drive you to do the best. You want to, when you go on test day, you want to just feel like, hey, I'm at home doing questions as practice. You don't want to feel like on test day you're doing something foreign. You want to be already in that routine, that habit of doing multiple choice questions all the time. Alternating study methods, again, that's great. If you feel like, hey, all I'm doing is questions and I'm feeling stuck, I'm not improving, then switch it up. Like, let me just do some videos for a little while. Let me read a textbook. Let me look at first aid and highlight some important things. That's important as well. Again, what to study in what order. Again, there's many ways people do it. Some people go systemically, some people go subject by subject. You want to find what works for you, build a consistent strategy, and stick with it. Crammable things, usually you can start leaning towards the end. Does not necessarily mean you shouldn't look at it at all. You should definitely review it, but things that you find, okay, pure memorization, micro, your biostats, those things you want to kind of have towards the end because those are fresh in your mind at that point. Things that require conceptualization, path, physio concepts, you want early to build that underlying knowledge. You want to know what a RAS system is. You want to know how the kidneys filter and everything like that early on. High yield material and previously learned material, repetitive learning is important, right? Things that are high yield for a reason. Learn what I always think about is common diseases. You want to know everything about them. Like diabetes, you got to know every single thing about diabetes. You got to know everything about rheumatoid. But like a rare condition that's not really seen very often, you just need to know the most important things about it. You don't need to know to the level of detail I know diabetes about, a membranous proliferative disease. You just need to know the big things about that. Time in the schedule for breaks, exercise, personal issues. Always, account for that. Don't over schedule yourself. Think, okay, I'm going to do 300 questions a day and just try to stick like that. That's not reasonable. Try to find balance. Try to work up. Start with 1 block, then go to 2 blocks, and then see how you do. See how your body reacts to it. And you want to build up that stamina because on exam day, it is a marathon. It's a long, grueling process, and you don't want to be burnt out. Stay relaxed, stay grounded. All right, well, what about the next stuff, right? So let's go to the next slide here. The day of the exam. Okay, so this is the big scary day that you always keep kind of build up in your mind, but always remember, sleep is your best friend. Don't stay up cramming the night before the exam. That's my biggest tip I would give. Definitely you want to be well rested on the day of exam. You don't want to feel like you're dozing off. You don't want to feel like, oh, I wish I slept more. I know it's anxiety provoking, but have a routine. Don't study in bed. Have good sleep hygiene. When you get into bed, you should just sleep off, wake up at a good time, enough time for you to do all your morning routine before you get to the test center. Don't feel like you have to rush to the test center. There's lots of little things like that you don't think about until the exam day. You want to think about early and plan. Understand your body, right? Everybody's different. Understand what foods make you sleepy, what foods give you energy, what foods make you go to the bathroom. So be aware of that. Caffeine intake, again, don't do anything crazy and experiment, right? I'm normally a 1 coffee a day drinker, but on the exam day, I'm drinking 5. That's gonna negatively affect you. Stick with what works for you, what's been working for you. If I drink 2 coffees a day normally, I try to stick with that on the exam day. If I have medications I normally take when I study, stay with that. I wouldn't experiment on the exam day and that be the reason why you do bad. You want it to feel like every other day you're just practicing questions. Using breaks wisely is also important. You do have, that break time, you can break up however you want. For me personally, I took a break between every single block. I know friends that took it to 2 blocks in a row, then took a bigger break. For me, I just needed to mentally let that block be finished. After a block, I would get up, even if it was like 2 minutes of just standing up and going outside and come back in, it would mentally be like, okay, that block is over. I don't need to focus on stuff that was difficult in the previous block. I don't need to think, oh, that question, what was that? Let me start looking it up and try to think. I have to mentally get ready for the next one so that I don't obsess over a question that, could be an experimental question like Jeff said. Could be something that didn't even matter, but I don't want it to negatively affect my future blocks. And that's a big tip I would say as well.